Hello class, this is Emergency Medical Responder Chapter 8, Professional Rescuer CPR. I'm going to review now the competencies for Professional Rescuer CPR in the next few slides that we're going to cover in this discussion. The first thing we're going to talk about is shock and resuscitation. Shock and resuscitation uses assessment information, that's the information you gain from your patient assessment, to recognize shock, respiratory failure, or arrest, and cardiac arrest, all based on your assessment findings, and then helps you manage this emergency while awaiting additional emergency response. Assessment uses scene information and simple patient assessment findings to identify and manage immediate life threats and injuries within the scope of the practice of the EMR. That is within your scope of training. We're going to talk about your primary assessment first. The primary assessment is used for all patient situations, and this is covered in detail on page 144 in your text. Also included in your primary assessment helps you determine the patient's level of consciousness, which is covered on pages 146 and page 149 in your text. Assessment also includes the assessment of airway, breathing, and circulation, or your ABCs, pages 144 and 145 in your book. Identification of life threats, that's page 144 in your book. Assessment of vital functions, that's pages 144 and 145 in your text. And your assessment helps you begin interventions needed to help preserve life. That's page 144 in your text. Included in these standard competencies that we're going to talk about more in detail for EMR response are the understanding of anatomy and physiology, which uses simple knowledge of anatomy and function of the upper airway, heart, vessels, blood, lungs, skin, muscles, and bones as the foundation of emergency care. Pathophysiology uses simple knowledge of shock and respiratory compromise to respond to life threats. Cardiopulmonary resuscitation, or CPR, consists of three major skills: circulation, which is C, airway, which is A, and breathing, which is B. Airway and breathing skills may be life-saving for a patient whose heart is still beating. In most cases, the patient's heart has also stopped beating. I will let you know that when respiration fails, it won't take long for the heart to follow. Rescue breathing alone will not save these patients. The circulatory system must be functional to carry oxygen to the body. To maintain or restore circulation manually, perform cardiac compressions or closed chest cardiac massage. To maintain both breathing and a heartbeat, rescue breathing and chest compressions must be done together. Approximately 70% of patients who experience cardiac arrest are in a state of what is called ventricular fibrillation, which means that only the ventricles of the heart are actually active. In this condition, the heart muscle is basically quivering and it is not effectively pumping blood. An automated external defibrillator, or AED, can help these patients. To understand why CPR is so effective, we need to talk about the anatomy and function of the circulatory system. The circulatory system consists of three components: a pump, which is obviously the heart, a network of pipes, which are the blood vessels, and fluid, which is the blood going through those vessels and heart. The heart, which is roughly the size of your fist, is located in the chest between the lungs. It's right behind the sternum. The heart consists of 4 chambers, 2 on the right side and 2 on the left side. Each upper chamber is called an atrium. The right atrium receives blood from the veins of the body. The left atrium receives highly oxygenated blood from the lungs. Each lower chamber is called a ventricle. The right ventricle pumps deoxygenated blood to the lungs, and the left ventricle pumps highly oxygenated blood throughout the body. The 4 chambers of the heart work in a well-ordered sequence to pump blood to the lungs and the rest of the body. One-way valves in the heart and veins allow blood to flow in only one direction through the circulatory system. This is figure 8-1 from your text, and you need to look at it carefully. Pay attention to the arrows and how the blood flows through the chambers and through the major blood vessels so that you understand clearly how the pump or the heart works to circulate blood. This is a very important illustration that you need to become completely familiar with. Arteries carry blood away from the heart at high pressure. Smaller arteries eventually branch into capillaries, which are the smallest pipes in the circulatory system. Veins are thin-walled pipes that carry blood back to the heart. And the easiest way to remember it is if you think of arteries carrying blood away, then you remember that arteries carry blood away from the heart at high pressure. And the veins are under lower pressure, and they bring the deoxygenated blood back to the heart and lungs for reoxygenation and subsequent recirculation. So arteries away. There are 4 major artery locations where you can easily determine pulse, the strength of the pulse, etc. These main 4 artery locations are in the neck, which are the carotid arteries, the wrist, which are the radial arteries, the arm, which are the brachial arteries, and the groin, which are the femoral arteries. Because these arteries lie between a bony structure and skin, you can palpate them easily and use them to measure the patient's pulse. A pulse is generated when the heart contracts and sends a pressure wave through the artery, moving the blood. This is figure 8-2 from your book, and it shows the locations for assessing the patient's pulse. And I want to point out specifically the picture on the top left. That is the carotid artery. And people get this confused frequently. The easiest way to remember the difference between the carotid arteries and the jugular veins, which are very close to each other, is to remember that next to the windpipe, there's a little groove. The windpipe is round. So next to the windpipe, on either side, there's a little groove, and the carotid arteries run one on each side down either side of that windpipe. So you measure that carotid pulse always with your fingertips, never your thumb, because it has its own pulse. But you measure that carotid pulse by putting pressure on the groove next to the windpipe itself. If you're pushing on the side of the neck, that's where the jugular vein is, and that is the incorrect location. Blood itself is made up of several components. There's plasma, the red blood cells, and the red blood cells are the cells that carry oxygen from the lungs to the body and then subsequently bring carbon dioxide back to the lungs. The white blood cells are called infection fighters because they devour bacteria and other disease-causing organisms. and platelets, which are the cells that allow blood to begin the clotting process. Plasma is simply the fluid that carries the red blood cells, white blood cells, and platelets. Now let's talk about cardiac arrest. Cardiac arrest occurs when the heart stops contracting and no blood is being pumped through the blood vessels, and subsequently the body, of course. Without a supply of blood, the cells of the body will begin to die because they cannot get the oxygen that they need and the nutrients that they need, and they cannot eliminate waste products. Some organs are more sensitive to low oxygen levels than others. For instance, the brain. It is the #1 consumer of oxygen, and as a result, it is the most sensitive to loss of oxygen, and brain damage can begin within 4 to 6 minutes after cardiac arrest. Brain damage. Within 8 to 10 minutes, the damage to the brain may become completely irreversible. So it's a very narrow window of time. Now, there are many different causes of cardiac arrest, and let me clarify something for you. Very often, people use the term heart attack and cardiac arrest interchangeably. They are not the same thing. There are many reasons that a heart can go into cardiac arrest, up to and including a heart attack. So let's go over these causes of cardiac arrest. There can be your patient who has heart and blood vessel disease, such as atherosclerosis, for instance, which can lead to heart attack and stroke. Cardiac arrest can also result from respiratory arrest. Remember, I mentioned if breathing stops, the heart will soon follow. Cardiac arrest can also occur as a result of a medical emergency such as epilepsy, diabetes, allergic reactions, electrical shock, and poisoning. It can also occur from drug overdose, drowning, suffocation, or trauma and shock caused by massive blood loss. A patient who has experienced cardiac arrest is unconscious and is not breathing. You cannot feel a pulse, and the patient looks dead, and technically they are. Regardless of the cause, however, the initial treatment is the same. You immediately begin providing CPR. CPR requires 3 types of skills: circulation, airway skills, or the ability to manage the airway, and breathing skills. With airway and breathing skills, we talked about these specifically in the airway management chapter. And in that chapter, we addressed how to determine if an airway is open, how to correct a blocked airway by using the head tilt, chin lift, or the jaw thrust maneuver, and how to correct the absence of breathing by performing rescue breathing. To perform CPR, you must combine airway and breathing skills with circulation skills. First, check the patient for a pulse. If there is no pulse, correct the patient's circulation by performing external chest compressions, and you will have learned these skills in your American Heart Association CPR certification. By compressing the patient's sternum, you change the pressure in the patient's chest and force enough blood through the system to sustain life for a short period of time. CPR by itself cannot sustain life indefinitely. It is also important to note that you see this misrepresented quite often. When people begin CPR in the movies, the patient wakes up and everything's groovy, and that is not likely to happen. It's extremely unlikely. And because it is not as effective as the heart delivering oxygen on its own. CPR by itself cannot sustain life indefinitely. But once it is recognized that a patient is pulseless and not breathing, however, CPR should be started as soon as possible to give the patient the best chance for survival. CPR is keeping oxygen moving through the brain and the vital organs to help extend their chance for survival. However, many patients will need defibrillation and medication to be completely successfully resuscitated from cardiac arrest. Now we're going to talk about the cardiac chain of survival, and you will have certainly covered this also in your American Heart Association CPR certification. I mentioned that CPR alone is not sufficient to save lives, but it is the first treatment in the American Heart Association's chain of survival, and the links of this chain of survival include, in this order, the recognition of cardiac arrest and activation of the emergency response system. Next, immediate CPR, or beginning CPR immediately with emphasis on high-quality chest compressions. The next is rapid defibrillation. The next step is basic and advanced emergency medical services care. And the next link is advanced life support and post-arrest care. As an EMR, you can help the patient survive by providing early CPR with an emphasis on high-quality chest compressions and by making sure that the EMS system, or advanced life support, ALS, has been activated and those people have been notified and are on their way. Remember that the chain of survival, like any chain, is only as good as its weakest link. This is an illustration of the American Heart Association cardiac chain of survival. And let's review these links one more time. The first and most important is immediate recognition and activation of EMS. The next link is immediate high-quality CPR. The third link is rapid and early defibrillation. The fourth link is basic and advanced EMS. And the fifth link is ALS, or advanced life support and post-arrest care. And confusingly, they add a sixth link in the picture, which is post-arrest and recovery. That's just an extra link. Those first 5 links are the key essential links when dealing with cardiac arrest. CPR should be started on all non-breathing, pulseless patients unless they are obviously dead or they have a do not resuscitate or DNR order that is valid in your jurisdiction. If there is any concern about the validity of a DNR order, then you need to proceed with life-saving skills and let someone who is more advanced make the determination about the validity of the DNR order. I need to also indicate to you that if a family says this patient has a DNR but they cannot produce one, then your obligation is to the patient. The other thing is when we state obvious death, as responders, we cannot pronounce death in the field with a couple of exceptions. If there's obvious decapitation, obvious separation of the body in some dramatic way that would make life impossible. Those are about the only 2 times that or if there are obvious signs of lividity, where, in other words, the patient has been dead and the red blood cells have settled to the lowest point of gravity. So if there's obvious decapitation, obvious trauma where there's separation of large portion of the body, or the presence of lividity, other than that, we cannot pronounce death. The one other thing I didn't mention is rigor mortis, which is a temporary stiffening of muscles that occurs several hours after death. And if lividity is present, rigor mortis, or rigor as it is sometimes referred to, may have already come and gone. But if you see lividity, especially with the presence of rigor mortis, then the patient is obviously beyond help at that point. On this slide, I had already mentioned lividity, but there is one other sign of death, and that would be obvious evidence of tissue decomposition. Flesh decay occurs only after a person has been dead for more than 1 day. And if you've never been around it, the first time you ever are around it, you will absolutely know it. You should discontinue CPR only when effective spontaneous circulation and ventilation are restored or the patient begins to move. Resuscitation efforts are then transferred to another person with an equal or higher level of training who then continues CPR. You can continue CPR if a physician orders you to stop, and you can discontinue CPR when a patient is transferred to properly trained, more advanced EMS personnel. You can also stop CPR when reliable criteria for death, as we previously discussed, are recognized, and perhaps you may not even need to begin CPR depending on those criteria for death. And you can also discontinue CPR if you are too exhausted to continue resuscitation, environmental hazards endanger your safety, or continued resuscitation would place the lives of others at risk. So you may have multiple patients involved, and you're doing CPR on a patient, but you have other patients who are becoming drastically ill, who may have a better chance for survival. And that's called triage, and that's covered in a whole separate chapter. We're going to talk now about external cardiac compression. An adult patient in cardiac arrest is unconscious, has no carotid pulse, and is not breathing or maybe slightly gasping. Check for circulation by feeling the carotid pulse, and I told you where to do that, and look for lack of breathing or slight gasping. Now, slide your fingers into the groove between the larynx and next to the larynx, and that's where the carotid pulse lies. Keep your fingers there for at least 5 seconds, but no more than 10 seconds, and that's enough time for you to be sure that that carotid pulse is absent. But you want to make sure that you wait at least 5 seconds, but no more than 10 seconds, because the pulse could just be very, very slow. If there is no carotid pulse in an unresponsive patient, then you must begin chest compressions. The patient must be placed on a firm horizontal surface. You need to stand or kneel beside the patient's chest and face the patient. Your knees, if you're kneeling next to the patient, or if you're standing next to the patient, perhaps they're on a hard surface like a low office table or something like that, your knees should be even with their shoulders. Place the heel of one hand in the center of the patient's chest on the lower half of the sternum, and place the heel of the other hand on top and interlock your fingers. For steps on how to perform adult chest compressions, you need to see Skill Drill 8-1 in your text, and also remember that this will be covered, if you haven't taken it already, in your American Heart Association CPR certification training. If you're going to have to do external chest compressions on an infant, you need to bear the following things in mind. Infants are children that are 1 year or younger who have experienced cardiac arrest, and they will be unconscious and will not be breathing or maybe slightly gasping, but will have no brachial pulse. And the reason you check the brachial pulse, which is the pulse midway on the inside of the upper arm between the shoulder and the elbow, is because if you notice, babies have no necks. Their necks have not lengthened and have no structure. So, and because they're infants, their arteries lie closer to the surface of their skin because they don't have developed muscles. So the easiest way to determine pulse or absence of pulse in an infant is the brachial pulse, where that brachial artery is on the inside of the upper arm, again between the shoulder and the elbow. And it shows you how to do that here in this illustration. If you determine that an infant that's 1 year or younger has no pulse, you must begin chest compressions. You need to use your 2 middle fingers to compress the sternum, as you see in the illustration. Compress the sternum at least 1/3 the depth of the chest. Compress at a rate of 100 to 120 times per minute. Remember, their circulation is much faster than an adult. If you are the only rescuer, give 2 rescue breaths after every 30 chest compressions. If there are 2 rescuers present, give 2 rescue breaths after every 15 chest compressions. Place the infant on a solid surface or cradle the infant in your arm, as you see in the illustration here, when doing chest compressions. You will not need to use much force because infants are so small and their chests are much more pliable. Their bones are much more rubbery, literally. They don't have the hardened, solidified, strong bones of an adult yet. In a child, if you have to begin chest compressions, you can check their carotid pulse just like in an adult. And if there is an absence of pulse, to begin the external chest compressions on a child, remember that the signs of cardiac arrest in a child, and a child is age 1 year to the onset of puberty, which is 12 to 14 years, those signs of cardiac arrest are the same as those for an adult. Again, check their pulse at the carotid artery, just like you would for an adult. To perform chest compressions in the child, in smaller children, you want to place the heel of one hand in the center of the chest on the lower half of the sternum. And in larger children, perform chest compressions with 2 hands as with an adult. Just like an adult, they need to be, and an infant for that matter, they need to be lying on a rigid surface so you have resistance when you're giving chest compressions. You want to compress the sternum at least 1/3 the depth of the chest and compress the chest at a rate of at least 100 times per minute. It's not quite as rapid as an infant, but children are smaller than adults, obviously, and they have a higher circulatory rate as well. If you are the only rescuer, give 2 rescue breaths after every 30 chest compressions. If 2 rescuers are present, give 2 rescue breaths after every 15 chest compressions. For adult CPR, if this is involving 1 rescuer adult CPR, the CPR consists of 3 skill sets. providing chest compressions, opening the airway, and providing rescue breaths. If you are the only trained person at a scene, you must perform one rescuer CPR. Follow the steps in Skill Drill 8-2 in your book, and also the skills you will have learned from your American Heart Association CPR certification class. When performing one rescuer CPR, you must deliver chest compressions and rescue breathing at a ratio of 30 compressions to 2 breaths. 2 rescuer adult CPR is more effective than 1 rescuer CPR. 1 rescuer can deliver chest compressions while the other performs rescue breathing when you have 2 rescuers. The chest compressions and ventilations can be given more regularly and without interruption. To avoid rescuer fatigue, 2 rescuers should switch roles after every 5 cycles of CPR, and the CPR should not be interrupted for longer than 10 seconds. If possible, position yourselves on opposite sides of the patient, one near the head and the other near the chest. This allows for seamless and quick reversal of roles. Follow the steps outlined in Skill Drill 8-3 as well as your American Heart Association CPR training. For infant CPR, if there's 1 rescuer involved, the principles of CPR are the same for adults and infants, but slightly different techniques must be used. Follow the steps in Skill Drill performing 1 rescuer infant CPR. Position the infant face up on a firm, flat surface. Establish a level of responsiveness. Call for additional help if the patient is unconscious. Check the brachial pulse and check for signs of no breathing or only gasping. If the infant has no pulse and is not breathing or only gasping, begin chest compressions. Compress the chest 30 times with the pads of your fingertips at a rate of 100 to 120 compressions per minute and give 2 breaths. Remember, if you are alone, continue to give 30 compressions followed by 2 rescue breaths until other providers arrive or until the infant begins to move. I had said earlier it's very unlikely that people respond to CPR only. However, because infants and children typically do not have heart disease and are not likely to be victims of heart attack, and more often their cardiac arrest situation is due to a breathing or an airway interruption, you will find that sometimes they will actually respond without defibrillation. So that's just something to bear in mind. For 2 rescuer infant CPR, use the 2-thumb encircling hands technique for chest compressions. Place both thumbs side by side over the lower half of the infant's sternum and encircle the infant's chest with your hands. Compress the sternum at a rate of 100 to 120 compressions per minute and use a compression to ventilation ratio of 15 to 2. This 2-thumb encircling hands technique for chest compressions is covered not only in your text, but absolutely is covered in your American Heart certification training. The steps for child CPR are essentially the same as that for an adult. With 1 rescuer and 2 rescuer child CPR, remember a child is defined as a person between 1 year of age and the onset of puberty, which is roughly 12 to 14 years. The steps for the child CPR are essentially the same as for an adult, as I mentioned. However, some steps may require slight modification for a child. These variations are as follows. You need to use less force to compress the child's chest. and in small children, use only one hand to depress the sternum, 1/2 to 1/3 the depth of the chest. In larger children, you should use 2 hands and use less force to ventilate the child. They may be a large kid, but their lungs are not at full capacity than they will be once the child is grown into an adult. Follow these steps to administer CPR to a child. Establish the child's level of responsiveness and check for breathing. Check for circulation. If no pulse and no breathing or only slight gasping is occurring, deliver 30 chest compressions. Open the airway and give 2 effective breaths. Continue compressions and ventilations in a 30-to-2 ratio for 1 rescuer and a 15-to-2 ratio for 2 rescuers. Reassess the patient after 5 cycles of CPR and every 2 minutes thereafter. If you are alone with no communications device, perform 2 minutes of CPR before leaving the patient to activate the EMS system. It is important to know signs of effective CPR so you can assess your efforts to resuscitate the patient. Signs of effective CPR are where a second rescuer feels a carotid pulse while you are compressing the chest, the patient's skin color improves from blue or bluish to pinkish, the chest visibly rises during ventilations, and compressions and ventilations are delivered at appropriate rate and depth. There are complications of CPR that can occur, but these complications can be minimized by the proper use of techniques. You may have broken ribs. In other words, you may break a patient's ribs while delivering a compression. But the broken ribs aren't going to kill them, but a lack of heartbeat absolutely will. So bear that in mind. But to prevent the potential or the problem of breaking a patient's ribs, make sure you're using proper hand positioning and do not let your fingers come in contact with ribs. If you hear a cracking sound, check and correct your hand position, but definitely continue CPR. Another complication of CPR that can occur is gastric distension. Gastric distension is caused when too much air is blown too fast and too forcefully into the lungs, and it leaks over the epiglottis and into the stomach, and then the stomach gets larger and larger and larger and is distended because of air. Gastric distension causes that abdomen to increase in size, and a distended abdomen pushes on the diaphragm and prevents the lungs from inflating fully. Gastric distension often can cause regurgitation or vomiting. If regurgitation occurs, quickly turn the patient to the side, wipe out the mouth with your gloved finger, and then return the patient to a supine position. You can prevent gastric distension by making sure you have opened the airway completely and properly, and again, do not blow excessive amounts of air into the patient. It's just enough to make the patient's chest rise. Regurgitation or vomiting can occur as a complication of CPR, and it is called passive vomiting, and that is common during CPR, so responders should be prepared to manage this complication. You certainly don't want to bring it on by causing gastric distension because you're blowing too much air when you're giving ventilations. However, passive vomiting does happen, so be prepared to manage this complication. When cardiac arrest occurs, the muscle that keeps food in the stomach relaxes, allowing the contents of the stomach to back up. If the patient regurgitates while you're performing CPR, Immediately turn the patient onto his or her side to allow the vomitus to drain from the mouth. Clear the patient's mouth of remaining vomitus first with your fingers and then, if possible, with a clean cloth or large pieces of gauze that won't accidentally get stuck down their airway. Clean cloth is preferable. Use suction if it is available, but do your best to clear any and all vomitus from the patient's airway. If the airway is not cleared, there are two problems that may arise. The patient may breathe in or aspirate vomitus into the lungs. That is a very serious and deadly complication because the lungs do not have the ability to manage bacteria that exist in the stomach, and deadly pneumonia can set in as a result. Also, you may force vomitus into the lungs with your next artificial ventilation if you don't clear their airway properly. So these are two very important issues that you need to be aware of that may arise, and you need to do your level best to make sure that you prevent them from happening and handle them properly if they do. As soon as you have cleared away any vomitus, then continue rescue breathing. EMRs may find themselves alone with a patient that's in cardiac arrest, so you need to create sufficient space to operate. One of the first things you must do is create or find a space where you can perform CPR. You need 3 to 4 feet of space on all sides of the patient. This will give enough space so that rescuers, as they arrive, can change places if there are 2 of you, and ALS rescuers, as they arrive, can implement procedures, and an ambulance stretcher can be brought in. If there is not enough space around the patient, you have 2 options. You can quickly rearrange furniture in the room or arrange objects at a scene to make space, or drag the patient into an area that has more room. And we talked about moving patients with clothes drags and blanket drags, etc. in an earlier chapter. So this is where you would bring those skills into play. Each year in the United States, approximately 424,000 people die of coronary heart disease in an out-of-hospital setting. More than 70% of all of out-of-hospital cardiac arrest patients have an irregular heart electrical rhythm called ventricular fibrillation, also known as VFib. VFib is a rapid, disorganized, and ineffective vibration of the heart. An electrical shock applied to the heart will help defibrillate it and help the heart reorganize its vibrations into effective heartbeats. A patient in cardiac arrest stands the greatest chance for survival when early defibrillation is available. And if you think back to that chain of survival I talked about early defibrillation. To get defibrillators to cardiac arrest patients more quickly, most EMS systems are equipping EMRs with automated external defibrillators, or AEDs. These machines accurately identify ventricular fibrillation and advise the rescuer to deliver a shock if needed. The links in the chain of survival include recognition of cardiac arrest and activation of the EMS system, immediate CPR with emphasis on high-quality chest compressions, rapid and early defibrillation, basic and advanced EMS care, and advanced life support and post-arrest care. Again, those are those links of survival that I mentioned before. When performing automated external defibrillation, the steps for using an AED are listed in Skill Drill 8-4, and you will also have learned this in your American Heart Association certification. AEDs vary in their operation, so learn how to use your specific AED. You must have the training required by your medical director to practice this procedure. EMRs should successfully complete a CPR course through a recognized agency, as I mentioned, the American Heart Association. There are other organizations or agencies available: the Emergency Care and Safety Institute, the ECSI, the American Heart Association, which I mentioned, and the American Red Cross, or ARC, which I didn't mention, but is also widely available. EMRs should regularly update their skills by successfully completing a recognized recertification course. Your department should schedule periodic reviews of CPR theory and practice for all people who are trained as EMRs. But there's one thing you need to remember: that certification is yours, and it is up to you to make sure that you periodically look at your certification and recognize if your recertification date is approaching. There are legal implications of CPR. Advanced directives, living wills, and durable powers of attorney for health care are legal documents that specify the patient's wishes regarding specified medical procedures. Because you are not in a position to determine whether the advanced directive or living will is valid, CPR should be started on all patients unless obvious signs of death are present. If a patient has an advanced directive or living will, a physician at the hospital will determine whether you should stop CPR, and if you are ordered to do so, you must do so. Do not hesitate to start CPR on a pulseless, non-breathing patient, because without your help, the patient will certainly die. The chances of encountering legal problems are minimal if you perform a careful assessment of the patient before beginning CPR. Another potential legal pitfall is abandonment. Abandonment is a discontinuation of CPR without the order of a licensed physician or without turning the patient over to someone who is at least as qualified as you are. Your most important protection against possible legal action is to become thoroughly proficient in the theory and practice of CPR. Also, abandonment means that once you begin care on that patient, you are responsible for maintaining and continuing the care of that patient until you are able to turn them over to someone who is at least at your skill level or higher. Now let's summarize what we've covered in this very important chapter. The circulatory system transports oxygenated blood from the lungs to the rest of the body. Each beat of the heart produces a pulse which can be felt at various sites on the body, such as the inside of the wrist, which is the radial pulse, the neck, which is the carotid pulse, the inside of the upper arm, which is the brachial pulse, and in the groin, which is the femoral pulse. Cardiac arrest occurs when the heart stops contracting and no blood is pumped through the blood vessels. Brain damage begins within 4 to 6 minutes after the patient has experienced cardiac arrest. Within 8 to 10 minutes, the damage to the brain may become irreversible. We also talked about the chain of survival. The chain of survival is the recognition and activation of EMS, immediate high-quality CPR, rapid defibrillation, rapid and early defibrillation, basic and advanced EMS, ALS, and post-arrest care. These include the steps essential to successful emergency cardiac care. We also discussed that when you arrive at an emergency scene, you must first assess the area for potential safety hazards. If the scene is unsafe, make it as safe as possible for yourself and the patient. As you approach the patient, look for possible causes of illness or injury. Next, assess the patient by checking the responsiveness and CAB, which is circulation, airway, and breathing. If a patient is not breathing, you must breathe for him or her. Check for a pulse, and if it is absent, begin CPR. We also talked about how basic life support for adults and children follows the same general steps. Check responsiveness, airway, breathing, and circulation. Intervene at any point where the patient's airway is obstructed, if the patient is not breathing, or if the patient has no circulation. Open an infant's airway by using the head tilt chin lift maneuver if you do not suspect a spinal injury. But in infants, be careful not to hyperextend the neck, because that will cause their airway, which is basically just a tube when they're that underdeveloped, to pinch shut, and that could obstruct the airway. If the infant is not breathing, provide 2 initial breaths. If these breaths produce visible chest rise, check for a brachial pulse. If an infant does not have a pulse, or if the pulse rate is less than 60 beats per minute with poor perfusion or circulation, begin CPR. If you are alone, use 2 fingers to compress the chest 30 times at a rate of 100 to 120 compressions per minute to a depth equal to at least 1/3 the depth of the chest. After 30 compressions, give 2 breaths. If 2 rescuers are present, use the 2-thumb technique with the hands encircling the chest and provide 15 compressions to 2 breaths. The single most important cardiac arrest survival factor is early defibrillation. Indications for using an AED or automated external defibrillator are that the patient is unresponsive, not breathing, and is pulseless. Once a unit is turned on and pads attached to a patient's bare chest, the AED, automated external defibrillator, will analyze the heart rhythm and advise whether a shock is indicated. If a shock is advised, ensure that no one is touching the patient, deliver the shock, and immediately perform CPR for 2 minutes before reanalyzing the patient's rhythm. If no shock is advised, perform CPR for 2 minutes and then again reanalyze the patient's rhythm. Continue CPR and rhythm analysis until ALS or advanced life support personnel arrive. Now for a few review questions. Review question 1. A patient who is in cardiac arrest, A, does not require rescue breathing, B, does not have a pulse and is not breathing, C, should be considered dead after 10 minutes of CPR, or D, requires treatment that is beyond the scope of practice of the EMR. The correct answer is B. This is a patient who does not have a pulse and is not breathing. Review question 2. The majority of out-of-hospital cardiac arrest patients have an irregular heart electrical rhythm called ventricular fibrillation, also known as VFib. How is this rhythm characterized? A, rapid, disorganized, and ineffective. B, slow, disorganized, and ineffective. C, rapid but effective. Or D, no electrical activity at all. This is very important for you to know, so here's the correct answer. The answer is A. VFib is rapid, disorganized, and ineffective. In our third review question, Which of the following is not a sign of effective CPR? A. Compressions are delivered at a rate of 50 per minute. B. You can feel a carotid pulse during chest compressions. C. The patient's skin color begins to turn more pinkish from blue. And D. The chest visibly rises during ventilations. So which of these is not a sign of effective CPR? The answer is A. Compressions are delivered at a rate of 50 per minute. Class, thank you so much for your attention. This is an extremely important chapter. Make sure that you go through your skill sets and review them. Make sure that you pay close attention if you have not already taken your CPR certification class. Make sure you pay close attention when you do take the class. And as always, I encourage you to seek out your instructor if you have any questions or if you need anything clarified. Again, thank you for your time and attention. We will meet again for Chapter 9.